Thank you, Dr. Osama. As usual, very interesting and very impressive. Now we move to our second speaker, which is Prof. Riki. Prof. Riki will talk to us about Olumiant results above and beyond. نبتدي بروف ريكي. There will be a Q&A after Prof. Riki talk.
So these are my disclosures, and I'm just starting right into my presentation with the topic Revolution Olumiant for the management of rheumatoid arthritis. And I will also cover the topic efficacy and safety of baricitinib in rheumatoid arthritis. So the core clinical attributes of Olumiant are consistent efficacy across different populations, long-term maintenance of efficacy, rapid onset of effect, which is very important in rheumatology because it's new. It slows down the structural damage, which has been shown nicely by publications from Desiree van der Heide. And all as we can say from our experience now for 4 years in Germany, it is very good manageable. And what is also important, this new treatment is superior to the standard of care. So what are the data? Olumiant is superior to standard of care in the predefined endpoint of ACR20 at week 12 of the so-called RA Beam study, which was published by Peter Taylor and colleagues in the New England Journal of Medicine. And this was the study in the field which met the primary endpoint, and it has nicely been shown that in
Yes, this for technical problem, few seconds. But by the way, Germany is the heaviest prescriber for JAK inhibitor worldwide. They have a great experience. And by the way, she is interesting in patient-reported outcome. That's why we should concentrate on her in the discussion Q&A until this technical problem is solved.
methotrexate. And by the way, SDI and CDI is what we nowadays use more and more in Germany, for instance, replacing the DAS measurement. So what I mentioned before, cover the topic efficacy and structural damage, which has been shown nicely by publications from Desiree von der Heide. And also, what is also unique for Olumiant, you have two dosages. You have 4 and 2 milligram, and we will cover this topic in detail later. And the safety profile, as we can say from our experience now for 4 years in Germany, it is very good manageable. And what is also important, this new treatment is superior to the standard of care. So what are the data? Olumiant is superior to standard of care in the predefined endpoint of ACR20 at week 12 of the so-called RA-BEAM study, which was published by Peter Taylor and colleagues in the New England Journal of Medicine. And this was the study in the field which met the primary endpoint, and it has nicely been shown that in all parameters, Olumiant was superior to the TNF-alpha treatment with adalimumab. This has been shown for week 12, for week 24, and also for week 52 after 1 year. On the next slide, you can see that also the data which are more ambitious, the ACR50 over 52 weeks, have been clearly better over, of course, placebo, but also over adalimumab. So you can see on this slide rapid and sustained improvement of the signs and symptoms of the rheumatoid arthritis. And at multiple time points, this could have been shown until week 52 and even longer, what we know now. So there is also another measure which is widely used in Europe. It is the DAS28 high sensitivity CRP. And also on this slide, you can see that Olumiant plus methotrexate was superior to adalimumab plus methotrexate according to the mean change in the DAS28. On the next slide, you see the outcome for low disease activity, because many of our patients, especially the long-standing patients, reach low disease activity not with the previous available treatment. But you can see here that significantly more patients achieved low disease activity according to SDI and CDI measurement with Olumiant and methotrexate. And by the way, SDI and CDI is what we nowadays use more and more in Germany, for instance, replacing the DAS measurement. So what I mentioned before, also the structural damage has been inhibited by the treatment with Olumiant and methotrexate, and this has been shown up to 2 years by this publication. So again, the low disease activity, that means SDI below or equal 11, has been maintained in 2 methods of evaluation, in the non-responder imputation method, and also that is important in the as observed data. So the remission that is more ambitious is SDI below 3.3. You can see here that even that was reached in a relevant number of patients after year 1, and also for an additional 2 years in those patients which were treated with Olumiant. So for me, because I'm very much studying and very interested in patient-reported outcome, you can see here that measured by the HAQ-DI, the relevant minimally clinically important difference, which is equal or below 0.5, has been reached by the treatment with Olumiant, and also over the long time period of 2 years. So the physical function could be normalized with this treatment. which is very important because many of these patients had already long-standing disease. So now I would like to address another question. These are the EULAR recommendations for tapering of DMARDs. And this is important because many of our patients really want to take less drugs. And the EULAR says if a patient is in persistent remission after tapering, and that is important, the glucocorticoids, consider also tapering the TS-DMARDs like JAK inhibitors, or also the bio-DMARDs, especially if combined with a conventional DMARD. And so what are the data for tapering? What can we show you? We can show you data from a very nice study where it has been shown that patients do maintain their low disease activity or even remission when they are stepping down from 4 to 2 milligram. And this has been shown up to week 48. And what is even more important, that 2/3 of the patients who stepped down from 4 to 2 milligram maintained their low disease activity or remission, demonstrating that Olumiant can be given with a flexible dosing. So even more important, what happens to those patients who stepped back from the 2 to 4 milligram? And did they regain again when they were stepped up to 4 milligram? And also here I can show you then more than 2/3 of the patients who stepped back from 2 to 4 milligram regained their original status of low disease activity or remission. So this is very helpful. These are smaller numbers, but important is, and we tried this already in our clinical practice, this is possible. And it is also a patient's wish not to take so much drugs. And you can try whether you can taper down in special patients. Another patient's wish, and I studied this very much, and it was published in the Patient's Preference Journal, that many patients really like monotherapy. They don't like methotrexate. And Olumiant is the JAK inhibitor, which allows you to use in monotherapy. That is very important that you can use it in monotherapy. It is in the label that you can do like this. So now I'm opening up another chapter, a chapter which is very important for our patient. It is the chapter of pain. And I can show you that the reduction of pain is about 30% more effective with the treatment in comparison to the treatment with adalimumab, with Olumiant, baricitinib. And what is also important is that the reduction in pain is really rapid. This is what I realized in many patients, that they feel the significant improvement rapidly after around 2 weeks after start of this treatment. And this really makes a lot of difference to the patients because they are not developing this type of chronic pain, and they do not developing a pain-prone personality, which is so important for the course of the disease. So this is shown nicely on these graphs. There has been a 50% improvement in pain and also a 50% time reduction to pain improvement with Olumiant compared to the TNF treatment. At week 24, here you can see the data, but this was also maintained on a longer process. Again, coming back to the physical function, very important for our patient. And you can see here by the HAQ-DI over 52 weeks, how Olumiant plus methotrexate significantly improved the physical function all the time the patients got this treatment, and even over 2 and 3 years as we know now. Nothing is the result of clinical trial with data from the real world experience. And you can see here on this slide that already more than 200,000 patients globally with rheumatoid arthritis are now being treated with Olumiant in 71 countries over the world. And what I can also show you data from our German registry. This is the so-called RABBIT registry. And we compared the data with the clinical study RA Beacon, difficult to treat patients. And we could show here that the treat to target goals of remission or low disease activity were even reached more often by patient in our real-world RABBIT registry than those from the clinical trial RA Beacon. And there are similar data from our colleagues from Switzerland, published by Gilbert. They have been shown, and they showed even more nice data now, will be shown now at EULA this year, that baricitinib demonstrated a significantly higher drug maintenance than the non-bari group in the Swiss quality management registry. Also very good and valuable data. So after real world, we go to safety. And I show you here the safety data for up to 8.4 years. First of all, the data set is already nearly 4,000 patients. That means 13,000 patient years, which were evaluated. And what is reassuring, that no clinically significant differences were observed in this data set in the event rate of key safety measures between Olumiant 2 and 4 milligram and also placebo. That means serious infection, that means malignancy, that means cardiovascular problems or DVD and pulmonary embolism. We will cover this in a minute in detail. The event rates across safety measures were similar to those of the previously reported integrated safety analysis. So the event rate for DVD and pulmonary embolism was similar between the Olumiant 2 and 4 milli groups in the extended data set and was consistent with other targeted therapies for rheumatoid arthritis. So no new safety signals were identified in this data set up to more than 8 years, and the event rates were consistent with those previously reported. Let's go into detail for the different parts of the infections. Infections are of interest mostly herpes zoster with the JAK inhibitors, and we will see here that, of course, the rate of herpes zoster, as we know, is higher compared to other treatments. So the accounted 323 cases of herpes zoster, which were reported in the all-bari registry. But what is important, that the majority, nearly all, were not serious. They were mild or maximum moderate and not multidermal in severity. That is very important. Mostly were treated, and these rates were highest in Asia, not in the other parts of the world. So the visceral cases were only very few, to 0, maximum 1, but no really signal. We know that herpes zoster is elevated, and what we do now when we decide to allocate a patient to Olumiant, for instance, we try to do the Shingrix vaccination before. And we are so fortunate, since 1 year, it is also reimbursed by the insurances for our patients. So going to the other point of interest, this is venous thromboembolism. And what we learned during the last years is that the rate of venous thromboembolism, especially here in the Olumiant trials, compared to the real-world data on other treatment, and especially for the patients with rheumatoid arthritis, is not elevated. It is within the range of observational incidences with many other treatments with patients with rheumatoid arthritis. So you can see here the data, and if you go in detail, I did this some time ago, you see on one hand that these data do not increase over time in those patients, but what you can also do by analyzing these patients, that they all have certain risk factors. They are obese, they have had already a VTE in their history, and they are also maybe on continuous use of COX-IPs. These are risk factors which you could really eradicate by a good history. So what are the monitoring requirements, and when are you allowed to initiate a treatment with Olumiant? Of course, according to local guidelines, you have to screen for viral hepatitis and tuberculosis as for all biological therapies. And if there is a positive quantiferon test, there should be an antituberculotic treatment considered in patients with an untreated latent tuberculosis. And we do this sometimes because we also have people coming to Germany, especially from Russia, and there the incidence of latent tuberculosis is higher than in our other population. And also what I said before, the treatment should be initiated with caution in those patients with the risk factors as mentioned before for DVD or pulmonary embolism. So the monitoring guidance, important. Lipid parameters, 12 weeks after start of therapy. We do this already once after 4 weeks. And we see only slight elevations, which normally normalize. Of course, the routine controls of liver enzymes, hemoglobin, then renal clearance, and the hepatic transaminases, and therefore, according to local guidelines, routine treatment controls. So where do you not start a treatment with Olumiant? If you have a low hemoglobin, and also if you have low numbers of neutrophils and lymphocytes, and also important in the elderly population, if you have a creatinine clearance below 30 milliliters per minute, and of course, no patients with severe hepatic impairment. So for whom the 4 milligram dose is recommended, the 4 milligram demonstrated statistically significant improvements across multiple efficacy measures, as I have shown, head-to-head trial with adalimumab, but also in other trials. Superiority reached in ACR 20 and also significant changes DAS28 at week 12. So it had consistent efficacy measures across all trials, which were published now. And for us as clinicians, it has a very fast onset of action and also sustained efficacy over a long time. All our patients, which we really started treating with Olumiant in April 2017, are still on this treatment after 4 years. And this is really a great win also for the physicians, not only for the patients. So my specific topic are the patient-reported outcome, and it has nicely been shown that Olumiant really improves the patient-reported outcome, especially pain rapidly, the physical function, and fatigue, which is still a big problem and unmet need in rheumatology, and also the severity and duration of morning stiffness. So there are no significant differences in the frequency of adverse events between 2 and 4 milligram. So Olumiant 4 milligram once daily has several benefits, as I have shown to you. So 4 milligram is a recommended doses, but 2 milligram can be given for certain patients. So especially elderly patients and those who have a low creatinine clearance, and also if patients are taking drugs like probenecid, that should be really used with caution, and especially here in the lower dosage. So we can also use, but I'm very cautious here, if patients have a chronic or recurrent infection, then you really have to have the possibility to make really frequent checks. And what I showed you nicely is that you can go down, that you can taper from 4 to 2 milligram, and that you can step up back again if the patients lose their low disease activity or remission. So I'm at the end of my presentation, and I hope I could have given you a nice overview of the big advantages, evolution to revolution, with the new oral treatment with Olumiant in rheumatology for our patients with rheumatoid arthritis. We are in the lucky situation that we can already now for 4 years treat our patients continuously with this new drug. And I can tell you that nearly all patients are very happy with these advances in therapy. Thank you so much for your attention, and I would have loved to come to Saudi Arabia, and hopefully next year that will be possible again. Thank you very much for your attention.
Thank you very much, Dr. Ricky and Dr. Osama Higi. Very interesting, very fruitful. Now we open the floor for discussion, Q&A. Anybody have any question? You can proceed to
yes.
the microphone.
Can I ask Dr. Eric?
Okay.
Yes, Dr. Eric. Guten Nacht or Guten Morgen? Yeah.
Hello,
Yes, okay.
Guten Morgen.
You are following EULAR guideline. You start by JAK or start by TNF at the first line of treatment. Do you find any difference between both of them in real life?
Actually, the more and more we get good experience with the JAK inhibitors, and the patient's wish is not to self-inject, then we go rather rapidly to the oral opportunity with the JAK inhibitors.
Yes.
So we try to do shared decision making. This is also a EULAR recommendation as an overarching principle. And what is interesting in my experience, for instance, there is a clear gender difference. I don't know why this is the way, but my male patients really do prefer not to self-inject. Female patients are more open to self-inject. That is interesting. It is not studied so far.
Thank you.
Good. Any other question? I have a question for you, Dr. Ricky. We know that JAK inhibitors, they usually are fast in action. When do you call failure? When do you switch to another medication? After how many weeks of starting baricitinib or any other JAK inhibitor?
Actually, I try at least 3 months. That is my window. Because if you switch too rapidly, there are also coming contextual factors as long-standing pain or fibromyalgic symptoms, which overlay the real inflammatory symptoms. And you really have to understand what is in the core of the disease of the patient. Of course, many patients who have a long-standing disease are really fibromyalgic. And when I worked in Kuwait, I have been working there as a consultant for more than 10 years. I have seen these patients. At that time, it just started with the JAK inhibitors. And what is so good in the JAK inhibition is really the normally rapid onset of disease suppression. And that is so good also for the psychological well-being of these patients. It helps so much.
But I think that most of the patient is responding within 1 to 2 weeks. That minor part of the patient, we can expand the interval. But for me, I prefer 2 months, not 3 months, because if the patient not responding after 2 to 3 months, most probably this patient will not respond to JAK, and you can try different mechanism of action. Agree?
Absolutely agree. Don't take too long. I think 6 months is much too long, which we were used for methotrexate, for instance. But for the JAK inhibitors, we don't need this. And also another important point, which has become more and more realistic, that the bridging with the prednisone or corticosteroids is not so much more necessary, at least not for a long time.
Good.
Yes.
Thank you. Anybody have any question?
Actually, I had a very interesting experience just yesterday in my outpatient clinic. There was one patient who stopped the therapy with Olumiant because she said, well, it does not really help me. I don't take it anymore. And then we went back to conventional DMARDs because she wanted something back like methotrexate or whatsoever. It doesn't matter, leflunomide. And then yesterday she gave us an urgent call and she said, please send me a very rapid prescription of my old Olumiant. I want to return to Olumiant. It was so much better. Sometimes patients have to try, and you have to give them the opportunity to make their own decision in this way.
Thank you. Thank you, Prof. Ricky.